Do you want to successfully complete the D220 Objective Assessment exam? Then you are in the right place. Our website provides a list of questions and answers for your success in the D220 OA exam for free. We understand that acing your OA exam can be quite challenging. That's why we provide completely free exam guides and practice questions for you. In this video, we will cover questions from data flow, alert fatigue, HIPAA security, change management, and data standardization. So let's get started. 1. A cardiac nurse needs to review trending data for a patient experiencing blood glucose fluctuations after open heart surgery to adjust insulin protocols appropriately for the next shift. A. Provider orders. B. Medication administration record. C. Laboratory results. D. Nursing flow sheets. Can you guess the answer? Correct answer, D. Nursing flow sheets. Explanation. Option D is correct because nursing flow sheets track fluid status and blood glucose trends over time, providing the comprehensive trending data needed for protocol adjustments. Option A is incorrect because provider orders show planned care instructions but don't display actual patient glucose trends or fluctuation patterns over time. Option B is incorrect because the medication administration record documents medications given but doesn't show blood glucose trending data needed for analysis. Option C is incorrect because laboratory results show individual test values but flow sheets better display continuous glucose monitoring trends. Alright, let's break down the core concept behind this question about tracking blood glucose fluctuations after cardiac surgery. When a cardiac nurse needs to review trending data for glucose management, they need a documentation system that captures continuous monitoring over time, not just individual snapshots. Provider orders tell you what's planned but don't show actual patient data trends. The medication administration record documents what drugs were given, but doesn't display glucose patterns. Laboratory results show individual test values at specific points in time. But nursing flow sheets, these are designed specifically to track fluid status, vital signs, and yes, blood glucose trends continuously throughout shifts. They provide that comprehensive trending view that allows nurses to see patterns, identify when glucose spikes or drops typically occur, and adjust insulin protocols accordingly. This is why flow sheets are essential for managing complex cases like post-cardiac surgery patients, where glucose control directly impacts healing and recovery. 2. An informatics nurse discovers providers are free texting diagnoses instead of selecting standardized codes, which impacts billing accuracy and data exchange between facilities. A. Staff training deficiency. B. Workflow efficiency preference. C. Interoperability barriers. D. Documentation time constraints. Do you know the answer? Correct answer, C. Interoperability barriers. Explanation. Option C is correct because free text entries create interoperability barriers because unstructured data cannot be easily exchanged or interpreted between different healthcare systems. Option A is incorrect because this describes a knowledge gap rather than the fundamental impact of using free text instead of standardized codes. Option B is incorrect because while free text may seem faster, the question asks about the impact on billing and data exchange. Option D is incorrect because time constraints explain why providers free text, but don't describe the resulting technical problems with data sharing. Let's explore the theory behind why free text documentation creates such significant problems for healthcare data exchange. When providers type diagnoses as free text instead of selecting standardized codes, they're essentially creating data that only humans can read, not computers. Think of it like writing a letter in your own handwriting versus using printed letters that everyone can recognize. Interoperability. The ability for different healthcare systems to share and understand data completely breaks down with free text. Sure, staff training might help providers use the codes, and yes, free text might seem faster for documentation. Time constraints explain why providers do it, but the fundamental impact, the real problem this creates, is interoperability barriers. Without standardized codes, that diagnosis typed at Hospital A can't be automatically understood by Hospital B's system. Billing systems can't process it. Quality metrics can't be calculated. Population health data becomes useless. This is why standardized coding isn't just a preference, it's essential for modern healthcare to function across organizations. 3. A hospital implements a new clinical decision support system that generates excessive medication alerts, causing nurses to dismiss warnings without reading them thoroughly anymore. A. System configuration error. B. Alert fatigue phenomenon. C. Training inadequacy issue. D. Software malfunction problem. Can you guess the answer? Correct answer, B. Alert fatigue phenomenon. Explanation. Option B is correct because alert fatigue occurs when healthcare providers become desensitized to excessive warnings, potentially missing critical alerts that could prevent medication errors. Option A is incorrect because while poor configuration causes excessive alerts, the phenomenon of dismissing warnings due to oversaturation is alert fatigue. Option C is incorrect because the issue isn't about understanding the system, but rather becoming overwhelmed by too many notifications. Option D is incorrect because the system is functioning as programmed. The problem is with the number of alerts configured. To really understand why excessive alerts become dangerous, let's dive into the psychology of alert fatigue in clinical settings. Imagine you're a nurse, and every single medication you scan triggers 3 or 4 warnings. Drug interactions that aren't relevant. Duplicate alerts for the same issue, warnings about things already addressed. At first you read each one carefully, but after the 50th unnecessary alert in one shift, your brain starts treating them all as background noise. This phenomenon is called alert fatigue, and it's not about poor system configuration, though that's what causes it. It's not about inadequate training, nurses know the alerts are there. It's not a software malfunction, the system is working exactly as programmed. Alert fatigue is a documented psychological phenomenon where healthcare providers become so desensitized to constant warnings that they start dismissing everything, including the critical alerts that could prevent a serious medication error. The irony is that systems designed to improve safety can actually decrease it when they overwhelm users with too much information. 4. During a telehealth consultation, a nurse practitioner needs to ensure patient privacy while discussing sensitive mental health information with a remote patient. A. Disable video recording. B. Use encrypted platform. C. Avoid speakerphone option. D. Require password authentication. Do you know the answer? Correct answer, C. Avoid speakerphone option. Explanation. Option C is correct because speakerphone options present significant privacy concerns in telehealth because others nearby could overhear protected health information being discussed. Option A is incorrect because recording policies do not address the immediate privacy risk of others overhearing the live conversation. Option B is incorrect because while encryption is important, the specific privacy risk mentioned in telehealth settings is speakerphone use. Option D is incorrect because authentication verifies user identity, but does not prevent privacy breaches from audio being overheard. This is a critical concept for telehealth privacy that goes beyond just using secure technology. When conducting a telehealth consultation for mental health, we have multiple layers of privacy to consider. Yes, you want an encrypted platform for data security. Yes, password authentication verifies who's accessing the session. And sure, disabling recording prevents future privacy breaches. But here's the immediate real-world privacy risk that's often overlooked: the speakerphone option. Think about it. The patient might be in their living room, their car, or a semi-private space. If they're using speakerphone, anyone nearby can hear both sides of this sensitive mental health discussion. Family members, roommates, even neighbours in thin-walled apartments. This isn't about technology failure, it's about sound travelling through physical space. Protected health information isn't just data on a screen, it's also spoken words that others might overhear. This is why avoiding speakerphone is specifically identified as a privacy concern in telehealth settings. 5. The emergency department and radiology use different information systems, but a patient's chest X-ray order must be accessible in both departments immediately. A. Master Patient Index. B. Continuity Care Record. C. Health Information Exchange. And D. Interface Connection Program. Can you guess the answer? Correct answer, A. Master Patient Index. Explanation. Option A is correct because the Master Patient Index links patient records across different departmental systems, ensuring the same patient is identified correctly in each system. Option B is incorrect because continuity care records transfer information between different healthcare organisations, not departments within the same facility. Option C is incorrect because health information exchange typically refers to sharing between different healthcare organisations rather than internal departments. Option D is incorrect because while interfaces connect systems, the Master Patient Index specifically manages patient identification across systems. Let's dig into how different departments within the same hospital share patient information when they're using completely different computer systems. The emergency department has one system, radiology has another, but that chest X-ray order needs to be accessible in both places immediately. You might think this requires a continuity care record, but that's for transferring between different healthcare organisations. Health information exchange typically means sharing between separate hospitals. An interface connection helps systems talk, but that's not what identifies the patient. The key here is the Master Patient Index. Think of it as the universal translator for patient identity. It's like having one master phone book that both departments reference. When the ED creates an order for John Smith, born January 15, 1980, the Master Patient Index ensures radiology's system recognises this is the same John Smith in their system, even if he's listed slightly differently. Without this index, you might have duplicate records, lost orders, or worse, the wrong patient getting the wrong test. 6. A quality improvement team needs to analyse why post-operative infections increased last quarter by examining multiple contributing factors and their relationships systematically. A. SWOT analysis template. B. Fishbone diagram tool. C. Benchmarking comparison method. D. Root cause analysis. Do you know the answer? Correct answer, B. Fishbone diagram tool. Explanation. Option B is correct because fishbone diagrams help teams visually diagram root causes of problems, allowing systematic analysis of multiple contributing factors rather than just symptoms. Option A is incorrect because SWOT analysis evaluates strengths and weaknesses for planning, but doesn't systematically trace problem causes. Option C is incorrect because benchmarking compares performance metrics across organisations, but doesn't analyse internal causative factors. Option D is incorrect because while root cause analysis investigates adverse events, fishbone diagrams specifically visualise multiple causative factors and relationships. Understanding how to systematically analyse quality problems requires the right visual tool, and here's why the fishbone diagram is perfect for investigating infection increases. When post-operative infections spike, you're not dealing with a single cause. It's a web of interconnected factors. A SWOT analysis looks at strengths and weaknesses for planning, not problem solving. Benchmarking compares you to others but doesn't dig into your internal issues. Root cause analysis investigates events, but the fishbone diagram, also called an Ishikawa diagram, specifically visualizes multiple contributing factors and their relationships. Picture an actual fish skeleton. The head is your problem, the infection increase. Each major bone represents a category like environment, procedures, people, equipment. Then smaller bones branch off showing specific factors, maybe inadequate hand hygiene, or ventilation issues, or surgical technique variations. This visual mapping lets teams see all potential causes simultaneously, identify patterns, and recognize how different factors interact to create the problem. It's about seeing the full picture, not just individual pieces. 7. A nurse discovers that cascading documentation in the electronic health record significantly improves workflow efficiency compared to traditional free text charting methods. A. Eliminates data duplication. B. Reduces overwhelming fields. C. Increases typing speed. D. Prevents medication errors. Can you guess the answer? Correct answer: B. Reduces overwhelming fields. Explanation. Option B is correct because cascading documentation reduces overwhelming data entry fields by presenting relevant options based on previous selections, making information easier to locate. Option A is incorrect because cascading documentation organizes data entry flow but doesn't specifically eliminate duplicate information storage. Option C is incorrect because cascading improves navigation and selection rather than actual typing speed for text entry. Option D is incorrect because while organized documentation helps, cascading specifically addresses data entry efficiency, not medication safety. Here's a game-changing concept in electronic documentation that dramatically improves nursing efficiency. Cascading documentation is like having a smart assistant that anticipates what you need to document next. Instead of facing a massive form with hundreds of fields, all visible at once, cascading presents relevant options based on what you've already selected. Think of it like a conversation. If you document that a patient has chest pain, the system then shows fields specific to cardiac assessment, not pediatric developmental milestones. This doesn't eliminate data duplication. The same information might still be stored multiple places. It doesn't increase your typing speed for free text. And while organized documentation helps with safety, that's not the primary benefit here. The key advantage is reducing those overwhelming data entry fields. Nurses aren't scrolling through irrelevant options or getting lost in massive forms. Each selection narrows down the next set of choices, making information easier to locate and document. It's about workflow intelligence, presenting exactly what you need when you need it. 8. Healthcare legislation passed in 2009 provides more rigorous enforcement of HIPAA violations and requires organizations to notify patients of data breaches. A. Our legislation. B. High-Tech Act. C. Meaningful Use Program. D. Cures Act. Do you know the answer? Correct answer: B. High-Tech Act. Explanation. Option B is correct because the High-Tech Act of 2009 strengthened HIPAA enforcement with stricter penalties and mandated breach notification requirements for protected health information. Option A is incorrect because ARA authorized incentive payments for EHR adoption, but High-Tech specifically addressed HIPAA enforcement. Option C is incorrect because meaningful use defines quality metrics for EHR usage rather than focusing on privacy enforcement. Option D is incorrect because the 21st Century Cures Act empowers patients with record access but doesn't strengthen HIPAA enforcement. Let's examine the critical healthcare legislation that transformed how we handle data breaches and privacy violations. In 2009, healthcare was facing a crisis of data security with minimal consequences for violations. HIPAA existed, but enforcement was weak. Then came the High-Tech Act, the Health Information Technology for Economic and Clinical Health Act. Now, ARA, the American Recovery and Reinvestment Act, was the broader economic stimulus that authorized incentive payments for EHR adoption. Meaningful use defined the quality metrics for using those EHRs. The 21st Century Cures Act came later to empower patients, but high-tech specifically targeted the privacy and security problem. It didn't just encourage better security, it put teeth into HIPAA enforcement with dramatically increased penalties, ranging from hundreds to $50,000 per violation. Most importantly, it mandated breach notification, meaning organizations must inform patients when their data is compromised. This wasn't just about technology adoption, it was about accountability. High-tech made data protection a serious business with serious consequences. 9. An employee injured at work requests their medical records, but their supervisor calls the nurse directly asking for information about the injury. A. Provide basic information. B. Refer to administration. C. Require signed agreement. D. Check HIPAA guidelines. Can you guess the answer? Correct answer, C. Require signed agreement. Explanation. Option C is correct because employee injury information requires a signed agreement before release to protect patient privacy rights, even for work-related incidents. Option A is incorrect because providing any information without proper authorization violates HIPAA privacy protections for employee health information. Option B is incorrect because administration cannot override HIPAA requirements. Proper authorization must be obtained regardless of referral. Option D is incorrect because HIPAA guidelines clearly require authorization. Checking them would confirm this requirement, not solve it. This scenario highlights a crucial privacy protection that applies even in workplace injury situations. An employee gets hurt at work, and naturally the supervisor wants information about the injury for workers' compensation or safety reports. The knee-jerk reaction might be to provide basic information, since it's work-related. Some might think referring to administration solves it, or that checking HIPAA guidelines will give an exception. But here's the fundamental principle. Employee health information is protected health information, period. Even when the injury happens at work, even when the employer is paying for treatment, that medical information belongs to the employee. The only way to legally share it is with a signed agreement from the employee specifically authorizing release for workers' compensation purposes. This isn't bureaucratic red tape, it's protecting the employee's privacy rights. They control what medical details their employer sees. Without that signed authorization, the nurse must refuse the request, regardless of who's asking or why they need it. 10. A nursing informatics specialist evaluates which data visualization method would best compare infection rates across multiple states for a quality presentation. A. Line graph display. B. Bar graph comparison. C. Pie chart percentage. D. Scatter plot correlation. Do you know the answer? Correct answer, B. Bar graph comparison. Explanation. Option B is correct because bar graphs effectively compare discrete values like infection rates across different states, making differences easily visible for presentation audiences. Option A is incorrect because line graphs best show trends over time rather than comparing values across different geographic locations. Option C is incorrect because pie charts show proportions of a whole rather than comparing independent rates across states. Option D is incorrect because scatter plots show relationships between two variables rather than comparing single metrics across categories. Choosing the right data visualization for healthcare presentations is both an art and a science, so let's explore why bar graphs excel at comparing infection rates across states. When you're presenting quality data to leadership or stakeholders, you need instant visual clarity. Line graphs are fantastic for showing trends over time, like how infections changed month by month, but not for comparing different locations at a single point. Pie charts show parts of a whole, like what percentage of infections were surgical versus respiratory, but can't effectively compare independent rates. Scatter plots reveal relationships between two variables, like staffing levels versus infection rates. But bar graphs, these are perfect for discrete comparisons. Each state gets its own bar, heights immediately show which states have higher or lower rates, and viewers can instantly grasp the differences. The human eye naturally compares bar heights, making patterns obvious. California's bar is twice as tall as Oregon's? That message is immediate. This visual efficiency is why bar graphs remain the gold standard for comparing metrics across categories. 11. The FDA mandates a specific technology to prevent medication administration errors by ensuring the right patient receives the right medication at bedside. A. Clinical decision support. B. Computerized provider entry. C. Barcoded medication administration. D. Electronic prescribing system. Can you guess the answer? Correct answer, C. Barcode medication administration. Explanation. Option C is correct because barcode medication administration helps verify patient identity and medication accuracy right when the medication is given. Option A is incorrect because clinical decision support provides alerts and recommendations to providers, but doesn't guarantee correct medication administration at the bedside. Option B is incorrect because computerized provider entry is used by prescribers to enter medication orders but doesn't verify the medication at the point of administration. Option D is incorrect because electronic prescribing transmits prescriptions electronically but doesn't ensure the right patient receives the right medication at the bedside. Understanding medication safety technology mandates reveals how seriously we take preventing drug errors at the bedside. The FDA didn't just recommend barcode medication administration. They mandated it as a critical safety standard. This isn't clinical decision support that provides alerts and suggestions. It's not computerized provider or order entry where doctors input orders. It's not just electronic prescribing that sends scripts to pharmacies. Barcode medication administration, or BCMA, creates a final safety check at the most critical moment. When the nurse is about to give the medication to the patient, think of it as a verification system. Scan the patient's wristband, scan the medication, and the system confirms this is the right drug for the right patient at the right time in the right dose, via the right route. The FDA recognized that most medication errors happen at the administration point, not in prescribing or dispensing. By mandating BCMA, they created a technological safety net that catches errors seconds before they could harm a patient. 12. During system implementation, involving frontline nurses in workflow redesign decisions helps overcome their resistance to adopting the new electronic health record. A. Training effectiveness strategy. B. Change management principle. C. Technology acceptance model. D. User interface design. Do you know the answer? Correct answer, B. Change management principle. Explanation. Option B is correct because change management involves employees in decision-making processes, reducing resistance by giving them ownership in the implementation process. Option A is incorrect because training addresses skill development after decisions are made, not involvement in the change process. Option C is incorrect because technology acceptance models explain user behavior but don't describe the involvement strategy. Option D is incorrect because interface design focuses on system usability rather than organizational change management strategies. Let's dive deep into why involving staff in implementation decisions is such a powerful change management strategy. When a new EHR system arrives, nurses often resist not because they're opposed to technology, but because they feel like victims of change rather than partners in it. This isn't about training effectiveness. You can train people perfectly on a system they hate. It's not about the technology acceptance model that explains behavior. It's not about user interface design making things pretty. This is pure change management principle in action. By involving frontline nurses in workflow redesign decisions, you transform them from passive recipients to active participants. They help decide how the system will work in their unit. They identify problems only they can see. They become invested in success because it's partly their creation. This psychological ownership is incredibly powerful. When people help build something, they want it to succeed. Resistance melts away because they're not being forced to accept someone else's solution. They're implementing their own ideas. 13. A diabetic patient's engagement with their care improves significantly when a specific condition is effectively managed by the healthcare team. A. Blood glucose stability. B. Pain under control. C. Medication compliance maintained. D. Education level increased. Can you guess the answer? Correct answer, B. Pain under control. Explanation. Option B is correct because patients whose pain is under control show significantly improved engagement with their care and better participation in treatment. Option A is incorrect because while glucose control is important, pain management has the strongest correlation with patient engagement. Option C is incorrect because medication compliance is an outcome of engagement rather than a primary driver of it. Option D is incorrect because education supports engagement, but pain control has the most direct impact on participation. Here's a fascinating insight into what truly drives patient engagement in their own healthcare. You might assume that stable blood glucose in diabetics would boost engagement, or that medication compliance drives participation, or that better education increases involvement. But research consistently shows one factor trumps all others: pain control. When patients are in pain, nothing else matters. They can't focus on education, they can't engage with their care plan, they can't even process information properly. Pain is all-consuming, but when pain is under control, everything changes. Suddenly patients can think clearly, participate in decisions, ask questions, follow treatment plans, and actually engage with their healthcare team. It's like removing a massive barrier that was blocking everything else. This isn't just about comfort, though that matters tremendously. It's about cognitive capacity. Uncontrolled pain literally hijacks the brain's ability to focus on anything else. That's why effective pain management isn't just compassionate care, it's the foundation that makes all other patient engagement possible. 14. The Centers for Medicare and Medicaid Services oversees a program requiring providers to demonstrate meaningful use of certified electronic health records. A. MIPS Quality Program. B. High-tech incentive payments. C. Meaningful use stages. D. Value-based reimbursement. Do you know the answer? Correct answer, C. Meaningful use stages. Explanation. Option C is correct because CMS developed and oversees the Meaningful Use Program with 3 stages requiring providers to meet specific EHR utilization criteria. Option A is incorrect because MIPS replaced meaningful use for physicians, but represents a different quality payment program. Option B is incorrect because high-tech authorized the incentives, but CMS specifically oversees the meaningful use program requirements. Option D is incorrect because value-based reimbursement rewards quality outcomes rather than specifically measuring EHR meaningful use. To understand healthcare quality programs, let's examine how the Centers for Medicare and Medicaid Services drives nationwide EHR adoption through meaningful use. CMS didn't just create guidelines, They oversee the entire meaningful use program with its 3 progressive stages. Now, MIPS is a different quality program that replaced meaningful use for physicians. High-tech authorized the money, but doesn't run the program. Value-based reimbursement rewards outcomes, not EHR use specifically, but CMS and meaningful use. This is the perfect partnership of federal oversight and technology requirements. Stage 1 gets providers capturing and sharing basic electronic data. Stage 2 advances to patient engagement and clinical processes. Stage 3 focuses on improved outcomes and comprehensive interoperability. CMS monitors compliance, distributes incentive payments, and penalizes non-participants. They're not just encouraging EHR use, they're requiring providers to demonstrate meaningful use. Using the technology in ways that genuinely improve care quality, safety, and efficiency. Without CMS oversight, meaningful use would be just another suggestion. 15. A nurse needs to document a patient's current isolation status for MRSA infection to ensure proper precautions are followed by all staff. A. Provider order section. B. Nursing flowsheet area. C. EMR information tab. D. Medication administration record. Can you guess the answer? Correct answer, C. EMR information tab. Explanation. Option C is correct because EMR information tabs guide isolation decisions and document current precaution requirements for conditions like MRSA requiring contact precautions. Option A is incorrect because while orders initiate isolation, the EMR information tab maintains current isolation status for reference. Option B is incorrect because flowsheets track vital signs and assessments rather than maintaining isolation status information. Option D is incorrect because the medication record documents drug administration, not infection control precaution requirements. Managing infection control in the electronic age requires understanding exactly where critical isolation information lives in the EMR. When a patient has MRSA, every single person entering that room needs to know about contact precautions immediately. The provider order section shows the initial isolation order, but that's historical. What was ordered, not current status. Nursing flowsheets track vitals and assessments, not isolation requirements. The medication record shows antibiotics being given, but not precaution status. The EMR information tab. This is the command center for isolation management. It's designed to be the single source of truth for current precaution requirements. This tab guides isolation decisions, displays active precautions prominently, and ensures everyone from housekeeping to physicians sees the same critical information. Think of it as a digital sign on the door that can't be missed or removed. It updates in real time, shows specific precaution types, required PPE, and special instructions. For MRSA requiring contact precautions, this tab ensures gloves and gowns are worn. Proper hand hygiene is followed and equipment stays in the room. 16. Query-based exchange within health information exchange systems proves most valuable during unplanned patient care situations requiring immediate information access. A. Scheduled surgery preparation. B. Emergency room visits. C. Routine clinic appointments. D. Discharge planning process. Do you know the answer? Correct answer, B. Emergency room visits. Explanation. Option B is correct because query-based exchange allows providers to quickly find and request patient information during unplanned emergency department visits when immediate access is critical. Option A is incorrect because scheduled surgeries allow time for directed exchange of records rather than requiring immediate queries for information. Option C is incorrect because routine appointments typically have established records readily available, lessening the need for urgent information queries. Option D is incorrect because discharge planning is a planned process, permitting directed exchange of information rather than relying on immediate queries. Query-based exchange is a lifesaver in healthcare emergencies, and here's exactly why it's designed for unplanned situations. Imagine an unconscious patient arrives at your emergency department. No medical records, no medication list, maybe from out of state. With scheduled surgery, you have time for directed exchange, sending specific records. Routine clinic visits use established records. Discharge planning is organised and methodical, but emergency rooms face the unknown every minute. Query-based exchange lets ED staff instantly search for and pull patient information from any connected healthcare system. It's like having a medical detective that can quickly ask every hospital and clinic in the network, "Do you have records for this patient?" Within seconds, previous diagnoses appear, medication allergies surface, recent test results download. This isn't about convenience, it's about making life-saving decisions with complete information. That patient who can't tell you they're allergic to penicillin. Query-based exchange finds that critical information when seconds count. 17. An informatics nurse implements authentication and encryption requirements for all mobile devices used to access electronic protected health information. A. Physical security measure. B. Administrative safeguard protocol. C. Technical safeguard requirement. D. Workflow optimization strategy. Can you guess the answer? Correct answer, C. Technical safeguard requirement. Explanation. Option C is correct because authentication and encryption on mobile devices are technical safeguards required for protecting electronic protected health information access. Option A is incorrect because physical security involves tangible protections, like locks, rather than digital authentication and encryption. Option B is incorrect because administrative safeguards involve policies and training rather than technical device security measures. Option D is incorrect because these are security requirements rather than workflow improvement strategies. Protecting electronic health information on mobile devices requires specific technical safeguards, and here's why authentication and encryption are classified as technical, not physical measures. Physical security would be things like cable locks, secure storage rooms, or locked cases, tangible barriers you can touch. Administrative safeguards involve policies, training, and procedures, the human element of security. Workflow optimization is about efficiency, not security. But authentication and encryption, these are pure technical safeguards, digital protections built into the technology itself. Authentication ensures only authorized users can access the device. Think passwords, fingerprints, or facial recognition. It's the digital bouncer checking IDs at the door. Encryption scrambles the data, so even if someone steals the device, they can't read the information without the decryption key. It's like putting health records in a digital safe that only opens with the right combination. Together, these technical safeguards create layers of digital protection. 18. Health Level 7 standards enable consistent data exchange between different healthcare information systems by establishing specific formatting rules. A. Security protocols. B. Interface connections. C. Data standardization. D. Workflow processes. Do you know the answer? Correct answer, C. Data standardization. Explanation. Option C is correct because HL7 provides standardization frameworks ensuring data maintains consistent meaning when exchanged between different healthcare information systems. Option A is incorrect because HL7 focuses on data format and structure rather than security protocols for protection. Option B is incorrect because while HL7 facilitates connections, its primary purpose is standardizing data format and meaning. Option D is incorrect because HL7 standardizes data exchange formats rather than defining clinical workflow processes. Health Level 7 standards are the universal language of healthcare data exchange, and understanding their role reveals why interoperability actually works. HL7 doesn't handle security protocols. That's for other standards. It's not just about creating interface connections, though it enables them. It's not defining how clinical work gets done. HL7 is all about data standardization, creating consistent rules for how health information is formatted and structured. Think of it like agreeing that all road signs will use the same symbols worldwide. Without HL7, Hospital A might send a blood pressure as 120/80ths, while Hospital B expects systolic 120, diastolic 80. One system might use M for male, another uses 1 to. These tiny differences break communication. HL7 establishes the grammar and vocabulary for health data exchange, defining exactly how to structure messages, what fields go where, how to format dates, how to code diagnoses. This standardization means when any HL7 compliant system sends data, any other HL7 compliant system can receive and understand it perfectly. 19. A hospital's surgical information system uses RFID technology in patient identification labels to improve operating room efficiency and safety. A. Equipment location tracking. B. Patient movement monitoring. C. Medication verification system. D. Staff attendance recording. Can you guess the answer? Correct answer. B. Patient movement monitoring. Explanation. Option B is correct because RFID in surgical patient labels tracks patient movement through the OR suite, improving coordination and preventing wrong site procedures. Option A is incorrect because while RFID can track equipment, the question specifically mentions patient identification labels, implying tracking of patients, not equipment. Option C is incorrect because medication verification typically involves barcode scanning, which links medication to patient records, not RFID patient labels. Option D is incorrect because staff attendance is often tracked with separate systems, such as time clocks or badge scanners, not patient identification labels. RFID technology in surgical settings serves a critical safety purpose that goes beyond simple identification. When surgical information systems use RFID in patient labels, they're creating a real-time tracking system for the OR suite. This isn't about tracking equipment locations, though RFID does that too. It's not for medication verification. That's barcode scanning's job. It's not for taking attendance of staff. RFID patient labels enable patient movement monitoring throughout the surgical journey. Picture this. The moment a patient enters the OR suite, their RFID tag registers their location. Pre-op, operating room 3, recovery. The system knows exactly where each patient is at every moment. This prevents wrong site surgeries by confirming the right patient is in the right OR. It improves efficiency by showing when ORs are actually occupied versus scheduled. It enhances safety by ensuring patients don't get lost in the shuffle. This real-time location awareness transforms OR coordination from guesswork to precision. 20. The American Recovery and Reinvestment Act of 2009 authorized specific financial incentives for healthcare providers adopting interoperable health information technology. A. Quality bonus payments. B. Grant funding programs. C. Incentive payment system. D. Penalty avoidance credits. Do you know the answer? Correct answer. C. Incentive payment system. Explanation. Option C is correct because the ARA authorized incentive payments to specific hospitals and healthcare professionals for adopting and using interoperable EHR technology. Option A is incorrect because quality bonuses reward outcomes, while ARA incentives specifically promoted technology adoption. Option B is incorrect because the ARA provided direct incentive payments rather than competitive grant funding programs. Option D is incorrect because the ARA offered positive incentives for adoption rather than credits for avoiding penalties. The American Recovery and Reinvestment Act of 2009 was a game changer for healthcare technology adoption, and here's exactly how it transformed the landscape. During the economic crisis, ARA didn't just throw money at healthcare. It created a strategic incentive payment system specifically for EHR adoption. This wasn't quality bonus payments for good outcomes. It wasn't competitive grant funding where you might or might not get money. It definitely wasn't about avoiding penalties. That came later. ARA authorised direct incentive payments to eligible hospitals and healthcare professionals who adopted and meaningfully used interoperable health information technology. The keyword here is incentive. Positive rewards for taking action. Providers could receive tens of thousands of dollars for implementing certified EHR technology and demonstrating meaningful use. Medicare and Medicaid distributed these payments, creating a financial carrot that motivated even reluctant adopters. This wasn't charity or loans. It was earned money for modernizing healthcare delivery. ARA's incentive payment system triggered the largest and fastest digital transformation in healthcare history. 21. Biomedical device integration eliminates manual data entry errors by automatically capturing vital signs from monitoring equipment into health records. A. Reduces documentation time. B. Prevents transcription mistakes. C. Improves workflow efficiency. D. Electronically captures data. Can you guess the answer? Correct answer. D. Electronically captures data. Explanation. Option D is correct because biomedical device integration electronically captures vital signs directly from devices without requiring manual entry by healthcare staff. Option A is incorrect because while time savings occur, the primary function is electronic capture rather than time reduction. Option B is incorrect because preventing errors is a benefit, but the core feature is automatic electronic data capture. Option C is incorrect because efficiency improves as a result, but the fundamental capability is electronic data capture. Let's examine the transformative power of biomedical device integration and why it's revolutionizing vital sign documentation. When we talk about blood pressure monitors, cardiac monitors, and pulse oximeters connected directly to the electronic health record, we're describing a fundamental shift in how data moves from patient to chart. This technology doesn't just reduce documentation time, though. That's a nice benefit. It doesn't just prevent transcription mistakes, although errors do decrease. It's not primarily about workflow efficiency, even though nurses save time. The core feature, the game-changing capability, is that biomedical device integration electronically captures data directly from the monitoring equipment. No human interpretation, no manual typing, no paper transcription. The device measures the patient's blood pressure at 142/88, and that exact reading flows electronically into the health record. This eliminates the entire manual entry process, where errors creep in. Misread displays, typo errors, transposed numbers. The integration creates a direct pipeline from the patient's body through the device to the permanent record, ensuring accuracy and completeness that manual entry could never achieve. 22. A nurse informaticist discovers staff routinely ignore clinical decision support system alerts and needs to address this patient safety concern effectively. A. Disable unnecessary warnings. B. Educate importance training. C. Increase alert visibility. D. Document non-compliance incidents. Do you know the answer? Correct answer. B. Educate importance training. Explanation. Option B is correct because when clinical decision support system alerts are ignored, Educating staff on the importance of these warnings addresses the root behaviour issue. Option A is incorrect because disabling alerts without analysis could remove critical safety warnings along with unnecessary ones. Option C is incorrect because making ignored alerts more visible won't address why staff dismiss them without consideration. Option D is incorrect because documentation tracks the problem but doesn't solve the underlying issue of alert dismissal. Understanding how to fix dangerous alert dismissal behaviours requires diving into the root cause of why healthcare staff ignore critical warnings. When clinical decision support systems are routinely ignored, it's tempting to just disable the annoying alerts, but that could remove life-saving warnings. Making alerts bigger or more visible won't help if staff have already trained themselves to dismiss them. Documenting who ignores alerts tracks the problem, but doesn't solve it. The solution is education on importance training. Teaching staff why these alerts matter. Here's the psychology. When people don't understand the purpose behind warnings, they treat them as nuisances. But when you educate staff about real cases where alerts prevented medication errors, show them data on near misses caught by the system, explain how each alert protects specific patients, suddenly those annoying pop-ups become valuable safety tools. This isn't just technical training on how to click through screens. It's helping staff understand that behind every alert is a potential adverse event waiting to happen. Education transforms perception from the computer is nagging me to the system is helping me protect my patients. 23. The 21st Century Cures Act fundamentally changes healthcare delivery by recognising patients need increased control over their healthcare information. A. Mandates data sharing. B. Empowers patient access. C. Requires quality reporting. D. Standardises terminology use. Can you guess the answer? Correct answer, B. Empowers patient access. Explanation. Option B is correct because the Cures Act recognises patients need more power in healthcare, with information access being key to healthcare decision-making. Option A is incorrect because while data sharing improves, the Act's core principle empowers patients rather than mandating sharing. Option C is incorrect because quality reporting exists in other regulations. The Cures Act focuses on patient empowerment. Option D is incorrect because terminology standardization predates the Cures Act, which focuses on patient information control. The 21st Century Cures Act represents a fundamental shift in healthcare philosophy about who controls medical information. This isn't just about mandating data sharing between providers, though sharing improves. It's not primarily about quality reporting requirements that exist in other regulations. It's not focused on standardizing terminology, which predates this act. The Cures Act's revolutionary principle is empowering patient access to their own health information. Think about the traditional model. Patients had to request records, wait weeks, pay fees, and often received incomplete information. The Cures Act flipped this completely. It recognises that patients need more power in their healthcare, and access to information is the key to making that happen. Patients can now demand immediate electronic access to their entire health record. They control who sees it, how it's shared, and what's done with it. This isn't just convenience. It's recognising that informed patients make better decisions, catch errors, and actively participate in their care. The Act essentially declares that your health information belongs to you, not to the healthcare system. 24. Template-based charting in electronic health records provides immediate availability while reducing documentation errors compared to free text narrative notes. A. Faster data retrieval. B. Eliminates human errors. C. Structured data entry. D. Automated spell checking. Do you know the answer? Correct answer, B. Eliminates human errors. Explanation. Option B is correct because template-based charting uses structured options to ensure more accurate documentation than free text entry, primarily focusing on reducing errors. Option A is incorrect because while data retrieval may be faster, the primary advantage of template-based charting is the reduction of documentation errors. Option C is incorrect because structured data entry is the mechanism by which templates function, but the key benefit is the elimination of errors. Option D is incorrect because automated spell checking only addresses typographical errors, while templates prevent broader documentation errors and inconsistencies. Template-based charting revolutionizes documentation accuracy in ways that go far beyond simple convenience. When nurses use templates instead of free text narratives, they're using a system specifically designed to eliminate human errors at their source. Faster data retrieval is nice, but not the main point. Structured data entry is how it works, not why it's valuable. Automated spell checking only catches typos, not content errors. The transformative power of templates is that they eliminate human errors by removing the opportunity to make them. Consider medication documentation. Instead of typing gave Patina 2 aspirin tablets, where errors in spelling, dosage, and medication name could occur, the template presents drop-down menus. Select medication from a list, choose standardized dosages, pick validated routes. You literally cannot misspell aspirin if you're selecting it from a list. You can't accidentally type 200 milligrams when only approved dosages appear. Templates guide documentation through validated pathways, ensuring completeness, accuracy, and consistency. This isn't just about making documentation neater. It's about engineering errors out of the system entirely. 25. Triangulation methods in data analysis help healthcare organizations confirm information accuracy by examining data from multiple analytical perspectives. A. Statistical significance testing. B. Data accuracy confirmation. C. Predictive model validation. D. Benchmark comparison analysis. Can you guess the answer? Correct answer, B. Data accuracy confirmation. Explanation. Option B is correct because triangulation confirms data accuracy through multiple analysis methods, ensuring reliability of healthcare information for decision-making. Option A is incorrect because significance testing evaluates statistical relationships rather than confirming data accuracy through multiple methods. Option C is incorrect because model validation tests predictions, while triangulation specifically confirms existing data accuracy. Option D is incorrect because benchmarking compares performance metrics rather than verifying data accuracy through multiple approaches. Triangulation in healthcare data analysis is a powerful methodology for ensuring the information we base decisions on is actually accurate. This isn't about testing statistical significance of relationships between variables. It's not about validating whether predictive models will work correctly. It's not about comparing performance benchmarks with other organizations. Triangulation is specifically about data accuracy confirmation through multiple analytical perspectives. Imagine you're investigating whether patient satisfaction scores are truly improving. You don't just look at survey results, that's one perspective. Triangulation means also examining complaint frequencies, analysing social media reviews, checking readmission rates, and reviewing staff feedback. Each method provides a different angle on the same question. When all these different analyses point to the same conclusion, you can be confident the data is accurate. If they disagree, you've identified data quality issues that need investigation. This multi-method approach catches errors that single analyses miss, like survey bias, data entry mistakes, or sampling problems. In healthcare, where decisions affect lives, triangulation ensures we're not making critical choices based on flawed data. 26. An informatics nurse designs a survey to evaluate nursing staff opinions about new technology implementation in their clinical units? A. Workflow analysis method. B. Technology assessment tool. C. Staff evaluation technique. D. Opinion survey method. Do you know the answer? Correct answer. D. Opinion survey method. Explanation. Option D is correct because surveys are designed to gather and evaluate opinions, making it the most direct method to assess nursing staff perspectives on technology implementation. Option A is incorrect because workflow analysis focuses on examining and optimizing processes, not directly gathering staff opinions on a specific technology. Option B is incorrect because technology assessment focuses on evaluating the capabilities and features of a technology rather than the opinions of its users. Option C is incorrect because staff evaluation generally measures individual performance against set criteria, not the collective opinions about technology implementation. When an informatics nurse needs to evaluate staff opinions about new technology, choosing the right assessment method is crucial for getting honest, comprehensive feedback. Workflow analysis examines how work gets done, not what people think about it. Technology assessment evaluates system capabilities, not user feelings. Staff evaluation measures individual performance, not collective opinions about tools. The opinion survey method is specifically designed to capture what nurses really think about technology implementation. Surveys provide structured questions that everyone answers consistently, allowing you to identify patterns across units and shifts. They offer anonymity, which is critical. Nurses may not criticize a system face-to-face with management, but will be honest on an anonymous survey. Surveys can reach all staff, not just the vocal few who speak up in meetings. You can quantify responses. 73% find the system difficult to navigate, is more actionable than some nurses don't like it. The data helps identify specific problems. Is it training, interface design, or workflow integration? This structured feedback becomes the roadmap for improvement, turning vague dissatisfaction into specific fixable issues. 27. Root cause analysis provides a structured methodology for healthcare organizations to investigate serious adverse events and prevent recurrence. A. Quality improvement tool. B. Structured analysis method. C. Performance measurement system. D. Risk assessment framework. Can you guess the answer? Correct answer, D. Structured analysis method. Explanation. Option B is correct because root cause analysis is a structured method specifically designed for analysing serious adverse events to identify causative factors. Option A is incorrect because while RCA supports quality improvement, it's specifically a structured investigative method for adverse events. Option C is incorrect because RCA investigates specific events rather than measuring ongoing performance metrics. Option D is incorrect because RCA analyses past events to find causes rather than assessing future risk potential. Root cause analysis stands apart from other quality tools as the gold standard for investigating serious adverse events in healthcare. While it supports quality improvement, RCA is specifically a structured analysis method designed for deep investigation. It's not just measuring ongoing performance. That's what dashboards and metrics do. It's not assessing future risks. That's risk assessment's job. RCA is a systematic, structured method for analysing serious adverse events after they've occurred. Picture a patient fall that resulted in a hip fracture. You don't just document it and move on. RCA assembles a team to methodically work backwards from the injury. What was the immediate cause? The patient fell. Why? They were getting up alone. Why alone? The call light was out of reach. Why out of reach? New bed placement protocol. Each why peels back another layer until you reach root causes. maybe inadequate staff training on bed setup, or purchasing decisions that selected beds without integrated call systems. This structured excavation ensures you're not just treating symptoms but fixing fundamental system problems. 28. HIPAA violations for protected health information breaches result in civil monetary penalties with specific fine ranges per violation. A. Criminal prosecution only. B. License suspension penalties. C. 100 to 50,000. D. 1,000 to million. Do you know the answer? Correct answer, C. 100 to 50,000. Explanation. Option C is correct because HIPAA violations result in civil monetary fines ranging from $100 to $50,000 per violation occurrence. Option A is incorrect because HIPAA violations include civil monetary penalties in addition to potential criminal prosecution. Option B is incorrect because HIPAA penalties involve monetary fines rather than professional license suspensions. Option D is incorrect because individual violation fines range from hundreds to 50,000, though annual maximums reach millions. HIPAA violations carry serious financial consequences, and understanding the penalty structure reveals just how seriously the government takes privacy breaches. Criminal prosecution exists but isn't the only consequence. There are civil penalties too. License suspension might happen for egregious violations, but that's not the monetary fine structure. The 1,000 to million range is way off the per violation scale. The correct range is $100 to $50,000 per violation. Think about what this means practically. A nurse accidentally sends one patient's records to the wrong family? That could be a $100 fine if it's a first-time unintentional error. But a hospital system that knowingly fails to encrypt thousands of patient records? That's moving toward the 50,000 per violation range. And here's the kicker. It's per violation, not per incident. If you email unencrypted records of 30 patients, that could be 30 violations. The annual maximum can reach $1.5 million, but individual violations range from that modest 100 for honest mistakes to 50,000 for willful neglect. 29. Psychotherapy notes require special handling under Health Information Exchange standards because they contain particularly sensitive mental health information. A. Encrypted transmission required. B. Exempt from sharing. C. Patient consent mandatory. D. Restricted access protocols. Can you guess the answer? Correct answer, B. Exempt from sharing. Explanation. Option B is correct because psychotherapy notes are specifically exempt from sharing under US CDI standards due to their highly sensitive nature. Option A is incorrect because while encryption is important, psychotherapy notes are exempt from routine sharing altogether. Option C is incorrect because these notes are exempt from sharing rather than requiring special consent procedures. Option D is incorrect because exemption from sharing goes beyond just restricting access within organizations. Psychotherapy notes receive unique protection in Health Information Exchange because they contain the most intimate details of mental health treatment. These aren't just sensitive, they're considered so private that they get special handling beyond normal health records. Encrypted transmission is important for all health data, not just psychotherapy notes. Patient consent is typically required for many things, but that's not the special protection here. Restricted access protocols apply to lots of sensitive information. The unique protection is that psychotherapy notes are completely exempt from sharing under US CDI standards. This means when health information is exchanged between providers, psychotherapy notes stay behind. They don't flow through health information exchanges. They're not included in continuity of care documents. They're not part of standard data sharing agreements. Even with patient consent for general record sharing, psychotherapy notes remain exempt. They're the therapist's personal notes about impressions, analysis, and session details that go beyond basic treatment facts. This exemption recognizes that the therapeutic relationship requires absolute privacy to be effective. 30. A comprehensive study guide emphasizes that discharge planning should begin at a specific point to ensure effective care transitions. A. Day before discharge. B. On admission day. C. After treatment completion. D. During medication reconciliation. Do you know the answer? Correct answer. B. On admission day. Explanation. Option B is correct because discharge planning that starts on admission ensures comprehensive preparation for care transitions throughout the hospital stay, addressing needs proactively. Option A is incorrect because waiting until the day before discharge doesn't allow adequate time for complex planning and coordination of services. Option C is incorrect because planning after treatment completion is too late for effective discharge preparation and addressing post-discharge needs. Option D is incorrect because medication reconciliation is part of discharge planning, but not the starting point for a comprehensive approach. Effective discharge planning is like conducting an orchestra. Timing is everything, and the music must start from the very beginning. Waiting until the day before discharge is like trying to arrange a symphony during the final bow. Far too late. Waiting for treatment completion means you've missed crucial preparation time. Medication reconciliation is just one instrument in the discharge orchestra, not when the concert begins. The golden rule is that discharge planning starts on admission day. From the moment a patient enters the hospital, the countdown to discharge begins. That first day, you're already assessing. Will they need home health? Do they have family support? Are there stairs at home? Will they need equipment? Starting on admission gives you time to arrange services, order equipment, coordinate with insurance, teach family members, and address barriers. Complex discharges to skilled nursing facilities can take days to arrange. Home oxygen needs insurance approval. Family caregivers need training. By starting on day one, you transform discharge from a rushed, error-prone scramble into a smooth, safe transition. 31. Predictive modelling in healthcare analytics uses historical and current data patterns to forecast the likelihood of specific clinical events. A. Quality metric tracking. B. Event likelihood forecasting. C. Cost analysis projection. D. Workflow optimization planning. Can you guess the answer? Correct answer. B. Event likelihood forecasting. Explanation. Option B is correct because predictive modelling specifically uses past and current data to forecast the likelihood that clinical events will occur. Option A is incorrect because metric tracking monitors current performance rather than predicting future event likelihood. Option C is incorrect because while costs can be projected, predictive modelling in healthcare focuses on clinical events. Option D is incorrect because workflow planning uses current processes rather than forecasting event probabilities. Predictive modelling represents the crystal ball of healthcare analytics, using data science to peer into the future of patient care. This isn't about tracking quality metrics, that's retrospective reporting. It's not about analysing costs, though predictions can include financial elements. It's not about planning workflows based on current operations. Predictive modelling specifically focuses on event likelihood forecasting, using patterns from the past and present. Imagine you have thousands of patient records showing who developed sepsis and who didn't. Predictive modelling analyses all the factors: vital sign patterns, lab trends, demographic data, comorbidities, to identify subtle patterns humans might miss. Then it applies these patterns to current patients, calculating the probability each will develop sepsis in the next 24 hours. A patient might seem stable, but the model detects their white blood cell trend, slight temperature elevation, and recent surgery combine to signal 73% sepsis risk. This early warning allows intervention before obvious symptoms appear. The model literally uses mathematical algorithms to forecast which events are likely to occur. 32. Merit-based incentive payment system replaced meaningful use requirements for physicians while maintaining focus on healthcare quality improvement goals. A. Documentation efficiency metrics. B. Technology adoption rates. C. Quality care delivery. D. Cost reduction targets. Do you know the answer? Correct answer, C. Quality care delivery. Explanation. Option C is correct because MIPS ensures Medicare patients receive the right care at the right time, focusing on quality care delivery. Option A is incorrect because MIPS emphasizes care quality rather than just documentation efficiency metrics. Option B is incorrect because technology adoption was meaningful uses focus, while MIPS emphasizes quality outcomes. Option D is incorrect because while costs matter, MIPS primarily measures and rewards quality care delivery. The merit-based incentive payment system represents Medicare's shift from volume to value, replacing meaningful use for physicians with a broader quality focus. MIPS doesn't primarily measure documentation efficiency. That's about paperwork, not patient care. Technology adoption rates were meaningful uses obsession, getting everyone on EHRs. Cost reduction is important, but not a MIPS primary target. MIPS laser focuses on quality care delivery to ensure Medicare patients get the right care at the right time. The system scores physicians on 4 categories, but quality weighs heaviest. Are diabetic patients getting their eye exams? Are heart failure patients on the right medications? Are preventive screenings happening on schedule? MIPS transforms these quality measures into payment adjustments. Deliver great care, get paid more, fall short, get paid less. This isn't about checking boxes or having the latest technology. It's about measurable patient outcomes. Did blood pressure improve? Were readmissions prevented? Did patients get appropriate preventive care? By tying physician payments directly to care quality rather than care quantity, MIPS incentivizes what matters most. 33. Health literacy universal precautions approach treats all patients as potentially at risk for not understanding health information properly. A. Translation services required. B. 5th grade reading level. C. Visual aids mandatory. D. Interpreter presence needed. Can you guess the answer? Correct answer. B. 5th grade reading level. Explanation. Option B is correct because universal precautions for health literacy include using 5th grade reading level materials to ensure broad understanding by all patients, regardless of background. Option A is incorrect because translation services specifically address language barriers, not the general health literacy of English speakers. Option C is incorrect because while visual aids are helpful, focusing on reading level provides a broader foundation for understanding. Option D is incorrect because interpreters specifically assist with language differences, while health literacy universal precautions are for everyone. Health literacy universal precautions represent a fundamental shift in how we communicate health information, treating every patient as potentially at risk for misunderstanding. Translation services address language barriers, but that's different from literacy. Visual aids help, but aren't the universal standard. Interpreters solve language problems, not literacy issues. The universal precaution is using 5th grade reading level for all patient materials. Why 5th grade? Because nearly half of American adults read below this level, and even highly educated people prefer simple language when they're sick or stressed. This isn't dumbing down, it's smarting up our communication. Instead of utilize medications as prescribed for optimal therapeutic outcomes, we write take your medicine exactly as directed. Instead of monitor for adverse reactions, we say watch for side effects. 5th grade level means short sentences, common words, active voice, and clear instructions. It means assuming nothing about what patients understand. Just like universal precautions in infection control assume anyone could have an infection, health literacy universal precautions assume anyone could struggle. 34. Electronic prescribing capability becomes available during a specific stage of meaningful use implementation in healthcare organizations. A. Stage 1 requirements. B. Stage 2 advancement. C. Stage 3 focus. D. Initial implementation phase. Do you know the answer? Correct. Answer C. Stage 3 focus. Explanation. Option C is correct because Stage 3 of meaningful use focuses on improving patient outcomes, including full electronic prescribing capability implementation. Option A is incorrect because Stage 1 emphasizes basic electronic data capture rather than advanced prescribing functions. Option B is incorrect because Stage 2 advances clinical processes, but Stage 3 implements comprehensive electronic prescribing. Option D is incorrect because initial implementation focuses on basic EHR adoption rather than advanced prescribing features. Electronic prescribing capability evolves through meaningful use stages, reaching full implementation at a specific point in the journey. Stage 1 gets providers started with basic electronic data capture. Patient demographics, problem lists, medication lists. Stage 2 advances the game with clinical processes and patient engagement, including some e-prescribing features. But Stage 3, this is where electronic prescribing reaches its full potential. Stage 3 focuses comprehensively on improving patient outcomes through advanced technology use. Here, electronic prescribing isn't just sending scripts to pharmacies electronically. It's complete integration with clinical decision support, automatic drug interaction checking, formulary verification, prior authorization processing, and controlled substance prescribing. The system knows patient allergies, checks insurance coverage, suggests therapeutic alternatives, and tracks whether patients actually fill their prescriptions. This comprehensive e-prescribing in Stage 3 represents the maturity of health IT, not just digitizing paper processes, but fundamentally transforming how medications are prescribed, monitored, and managed. It's the difference between sending an electronic fax and having an intelligent system that actively prevents medication errors. 35. Tapping badge technology in healthcare documentation systems provides a specific efficiency improvement for nursing workflow processes. A. Security authentication enhancement. B. Documentation time improvement. C. Patient identification verification. D. Medication scanning acceleration. Can you guess the answer? Correct answer, B. Documentation time improvement. Explanation. Option B is correct because tapping badge technology allows for quick system access and user authentication, significantly reducing the time nurses spend logging in and out of documentation systems, thus improving documentation time. Option A is incorrect because while badge technology does enhance security authentication, the primary benefit in documentation systems is the time saved during the authentication process, not the security itself. Option C is incorrect because while badges can be used for identification, in documentation systems, they primarily identify the staff member, not the patient. Patient identification usually involves other methods. Option D is incorrect because medication scanning typically involves barcode technology on the medication itself, not the tapping of staff badges. Tapping badge technology in healthcare represents a brilliant solution to a persistent documentation problem: the time it takes to access systems repeatedly throughout a shift. This isn't primarily about security authentication, Though badges do verify identity, it's not about patient identification. Patients wear wristbands, not tap badges. It's not about medication scanning acceleration that uses barcodes on drugs. The key benefit is documentation time improvement through rapid system access. Picture a nurse's typical shift, entering 20 different patient rooms, accessing computers dozens of times, logging in and out repeatedly for security compliance. Traditional login means typing usernames and passwords each time. Maybe 30 seconds per login. But multiply that by 40 logins per shift. That's 20 minutes just typing passwords. Badge tapping reduces this to a quick tap. 2 seconds instead of 30. The math is simple, but the impact is profound. Those saved minutes mean more time for patient care, less frustration with technology, and better documentation compliance, because the system isn't a barrier. It's frictionless access that maintains security while dramatically improving workflow efficiency. 36. SNOMED clinical terms serves as a globally recognized controlled healthcare vocabulary, enabling consistent data capture across specialties. A. Billing code standardization. B. Common language provision. C. Workflow process mapping. D. Quality metric definition. Do you know the answer? Correct answer, B. Common language provision. Explanation. Option B is correct because SNOMED provides a common language for electronic health records, enabling consistent communication across all healthcare specialties. Option A is incorrect because while SNOMED supports coding, its primary purpose is providing common clinical terminology. Option C is incorrect because SNOMED standardizes terminology rather than mapping workflow processes. Option D is incorrect because SNOMED provides vocabulary rather than defining specific quality metrics. SNOMED clinical terms functions as the Rosetta Stone of healthcare, providing a universal clinical language that every healthcare system can understand. This isn't about billing code standardization. That's what ICD-10 handles. It's not about mapping workflows or defining quality metrics. SNOMED provides common language provision across all medical specialties and care settings. Imagine trying to share patient data between a cardiologist in New York and an emergency physician in California. Without SNOMED, one system might document heart attack, while another uses MI, and a third says myocardial infarction. They all mean the same thing, but computers don't know that. SNOMED assigns a specific code, 222980006, that means myocardial infarction in every system, every language, every country that uses it. This goes beyond simple translation. SNOMED captures relationships between concepts, clinical nuances, and hierarchies of meaning. It knows that aspirin is both an analgesic and an antiplatelet. It understands that pneumonia is a type of lung infection, which is a type of respiratory disorder. 37. Scope creep during project implementation occurs when unanticipated growth in user expectations leads to expanded project requirements. A. Budget overrun issues. B. Timeline extension problems. C. Unapproved requirement changes. D. Resource allocation conflicts. Can you guess the answer? Correct answer, C. Unapproved requirement changes. Explanation. Option C is correct because scope creep represents unapproved changes and uncontrolled growth in project requirements that can cause serious implementation delays. Option A is incorrect because budget overruns are a consequence of scope creep rather than its definition. Option B is incorrect because timeline problems result from scope creep but don't define the phenomenon itself. Option D is incorrect because resource conflicts may occur, but scope creep specifically means unapproved requirement expansion. Scope creep is the silent project killer that transforms manageable implementations into chaotic failures through uncontrolled requirement expansion. Budget overruns are a symptom of scope creep, not its definition. Timeline extensions result from it, but don't define it. Resource conflicts happen because of it, not as it. Scope creep specifically means unapproved requirement changes, the gradual, often unnoticed expansion of what a project is supposed to deliver. It starts innocently. While you're building the medication module, could you also add vaccine tracking? Then, and pediatric dosing calculations. Soon, we need drug interaction alerts too. Each request seems reasonable in isolation, but collectively they transform a 3-month project into a 2-year nightmare. The word creep is perfect. These changes creep in slowly, without formal approval, without additional resources, without timeline adjustments. The project that was supposed to digitize nursing documentation is now also handling scheduling, inventory, and billing. This unapproved expansion causes delays, cost overruns, team burnout, and often complete project failure. That's why change control processes exist, to prevent scope creep. 38. A patient portal allows individuals to manage their own health information online, though certain barriers limit widespread adoption. A. Technology skill requirements. B. Poor internet access. C. Insurance coverage limitations. D. Provider resistance factors. Do you know the answer? Correct answer, B. Poor internet access. Explanation: option B is correct because poor or no internet access represents a primary barrier preventing patients from utilizing personal health record portals. Option A is incorrect because while skills matter, lack of internet access is the fundamental barrier to portal use. Option C is incorrect because patient portals aren't typically restricted by insurance coverage limitations. Option D is incorrect because patient-facing portals depend more on patient access than provider acceptance. Patient portals promise to revolutionize how individuals manage their health information, but adoption faces a fundamental infrastructure barrier that no amount of technology can fix. Technology skill requirements matter, but can be taught. Insurance coverage doesn't typically limit portal access. Provider resistance might exist, but isn't the primary barrier for patients. The fundamental barrier is poor internet access. Without reliable internet, portals are useless. This digital divide affects millions. Rural communities with no broadband, urban poor with no home internet, elderly on fixed incomes who can't afford data plans. You can have the world's best patient portal, but if someone only has internet at the library, they can't check test results at home. If they have a flip phone, they can't use the mobile app. If their only internet is expensive cellular data, they won't download imaging results. This isn't about preference or skills, it's about access. The portal might be free, but internet isn't. 39. Data mining techniques in healthcare look for hidden patterns and relationships within large data sets to improve patient outcomes. A. Statistical analysis method. B. Hidden pattern discovery. C. Database optimization process. D. Information retrieval system. Can you guess the answer? Correct answer, B. Hidden pattern discovery. Explanation. Option B is correct because data mining specifically looks for hidden patterns and exceptions in large groups of healthcare data using specialized software. Option A is incorrect because while statistics are involved, data mining specifically seeks hidden patterns rather than standard analysis. Option C is incorrect because data mining analyzes content rather than optimizing database performance. Option D is incorrect because retrieval systems fetch known data while mining discovers unknown patterns. Data mining in healthcare is like having a detective with superhuman pattern recognition abilities examining millions of patient records simultaneously. This isn't standard statistical analysis that tests predetermined hypotheses. It's not about optimizing how databases run. It's not just retrieving information you already know exists. Data mining specifically focuses on hidden pattern discovery in massive datasets that humans could never process manually. Imagine you have 10 years of hospital data, millions of admissions, procedures, outcomes. Hidden in that data might be the pattern showing that patients who receive a specific medication combination have 30% fewer readmissions, but only if they're over 65 with diabetes and hypertension. No human would ever spot this specific combination among millions of possibilities. Data mining algorithms crawl through the data, testing millions of potential patterns, looking for hidden relationships and unexpected correlations. They might discover that infections spike when certain nurses work together, or that a specific lab value predicts complications 3 days before symptoms appear. These patterns were always there, hidden in plain sight, waiting for data mining to reveal them. 40. The informatics nurse's primary goal when working with electronic health records focuses on a specific patient care improvement area. A. Documentation compliance rates. B. Patient safety improvement. C. Workflow efficiency metrics. D. Technology adoption success. Do you know the answer? Correct answer, B. Patient safety improvement. Explanation. Option B is correct because the informatics nurse's primary goal is improving patient safety through electronic health record optimization and effective technology use. Option A is incorrect because compliance supports safety, but isn't the primary goal of informatics nursing practice. Option C is incorrect because workflow efficiency serves the larger goal of improving patient safety outcomes. Option D is incorrect because technology adoption is a means to achieve improved patient safety, not the primary goal. The informatics nurse's primary goal cuts through all the technology, metrics, and systems to focus on what matters most in healthcare. Documentation compliance is important but serves a larger purpose. Workflow efficiency helps but isn't the ultimate goal. Technology adoption is a means, not an end. The primary goal is patient safety improvement through optimized use of health information technology. Every system configuration, every training session, every workflow redesign, they all serve this singular purpose, keeping patients safe. When an informatics nurse adjusts alert thresholds, they're preventing medication errors. When they optimize documentation templates, they're ensuring critical information isn't missed. When they integrate barcode scanning, they're eliminating wrong patient errors. This isn't about making technology work, it's about making technology protect lives. The informatics nurse stands at the intersection of clinical care and information systems, constantly asking, how can this technology prevent harm? They're the guardians who ensure that our powerful digital tools enhance rather than endanger patient care. 41. Regression testing during system updates ensures that new changes don't negatively impact existing functionality in healthcare information systems. A. Performance speed verification. B. Security vulnerability assessment. C. Functionality preservation testing. D. User acceptance evaluation. Can you guess the answer? Correct answer, C. Functionality preservation testing. Explanation option C is correct because regression testing focuses on ensuring that existing functionality remains intact after updates or changes to the system. It's a way to catch unexpected side effects. Option A is incorrect because while performance is important, regression testing's primary goal is to verify that existing features still work as expected, not specifically to assess speed. Option B is incorrect because security vulnerability assessments are a separate type of testing that looks for weaknesses in the system's security, not for functional regressions. Option D is incorrect because user acceptance evaluation involves users testing the system to see if it meets their needs, while regression testing focuses on the technical aspects of maintaining functionality after changes. Regression testing is the unsung hero of system maintenance, ensuring that improvements don't accidentally break what already works perfectly. This isn't about checking if the system runs faster after updates. That's performance testing. It's not about finding security holes. That's vulnerability assessment. It's not about whether users like the changes. That's acceptance testing. Regression testing is specifically functionality preservation testing after system changes. Think of it like renovating one room in your house. You need to make sure you didn't accidentally break the plumbing in other rooms. When developers update the medication module, regression testing verifies that the lab results module still works. The admission system still functions, and the discharge planning features remain intact. It's called regression because you're checking that the system hasn't regressed, gone backwards in functionality. Every software update carries risk. Fixing one bug might create 3 new ones. Adding a feature might break existing features. Regression testing systematically verifies every existing function still works correctly. Without it, that helpful update on Monday becomes the disaster that crashes the entire system on Tuesday. 42. Benchmarking in healthcare quality improvement involves comparing specific performance metrics to identify best practices and improvement opportunities. A. Internal process analysis. B. Competitor performance comparison. C. Historical trend evaluation. D. Resource utilization review. Do you know the answer? Correct answer. B. Competitor performance comparison. Explanation. Option B is correct because benchmarking compares an organization's performance against the toughest competitors in the healthcare industry for improvement. Option A is incorrect because benchmarking specifically involves external comparisons rather than internal analysis alone. Option C is incorrect because benchmarking compares against other organizations rather than examining historical internal trends. Option D is incorrect because resource reviews examine internal usage, while benchmarking requires external comparisons. Benchmarking in healthcare quality improvement is like entering your hospital in a competition where everyone wins by learning from the best. This isn't internal process analysis where you only look at your own operations. It's not examining historical trends of your past performance. It's not reviewing how you use resources internally. Benchmarking is specifically competitor performance comparison to identify excellence and improvement opportunities. Imagine your hospital has a 3% surgical infection rate. Is that good or bad? Without benchmarking, you don't know, but when you compare against the best hospitals nationally and find they achieve 0.5% rates, suddenly you have a target and motivation. More importantly, you can study what those top performers do differently. Maybe they use different prophylactic antibiotics, or their pre-op preparation is more thorough, or their OR air filtration exceeds standards. Benchmarking isn't about copying clients, it's about learning from the best to become better. The word benchmark comes from surveying, where you measure everything against a fixed reference point. In healthcare, those reference points are the organizations achieving the best outcomes. 43. Clinical decision support systems must balance providing helpful information with avoiding overwhelming users through excessive alerts and warnings. A. Alert customization priority. B. Warning number control. C. Notification timing optimization. D. Message priority ranking. Can you guess the answer? Correct answer, B. Warning number control. Explanation. Option B is correct because controlling the number of warnings prevents alert fatigue. ensuring staff do not ignore critical messages due to oversaturation. Option A is incorrect because customization helps, but controlling total warning volume is the critical balance factor. Option C is incorrect because timing matters less than the total number of alerts overwhelming users. Option D is incorrect because ranking helps, but reducing overall warning numbers prevents fatigue more effectively. Clinical decision support systems walk a dangerous tightrope between being helpful and becoming harmful through alert overload. Alert customization helps, but isn't the core issue. Optimizing timing and ranking priorities are refinements, not the fundamental balance. The critical factor is warning number control, managing the total volume of alerts users receive. Here's the paradox: you want to warn about everything dangerous, but too many warnings create alert fatigue, where users ignore everything, including critical alerts. It's like the boy who cried wolf, except the wolf is a fatal drug interaction, and the boy is your computer system. Research shows that when clinicians receive more than 20 alerts per shift, their response rate plummets. They start clicking through warnings without reading, developing muscle memory to dismiss pop-ups. The art is controlling the number, keeping it low enough that each alert gets attention, but comprehensive enough to catch serious problems. This means ruthless prioritization. Suppress low-value alerts, combine related warnings, and only interrupt workflow for truly critical issues. The goal isn't maximum alerts, it's maximum effectiveness. 10 meaningful warnings that get acted upon save more lives than 100 ignored ones. 44. Gap analysis during electronic health record transitions identifies desired features unavailable in new systems requiring workflow adaptations. A. Training needs assessment. B. Feature availability comparison. C. Budget requirement analysis. D. Timeline feasibility study. Do you know the answer? Correct answer. B. Feature availability comparison. Explanation. Option B is correct because gap analysis lists features and functions desired but not immediately available in the new system being implemented. Option A is incorrect because training assessment follows gap analysis rather than being its primary purpose. Option C is incorrect because gap analysis focuses on functional differences rather than budget requirements. Option D is incorrect because timeline studies plan implementation, while gap analysis identifies functional gaps. Gap analysis during EHR transitions is like creating a detailed map of the canyon between where you are and where you need to be. This isn't about assessing what training people need. That comes later. It's not analysing budget requirements or studying timeline feasibility. Gap analysis is specifically feature availability comparison between current and future systems. Imagine you're moving from your old EHR to a new one. Your current system has a beloved feature where clicking one button orders a complete cardiac workup, EKG, troponin, chest x-ray, cardiology consult all at once. The new system doesn't have this. That's a gap. Your nurses rely on a specific medication calculator for pediatric dosing. The new system calculates differently. Another gap. These gaps aren't necessarily problems. Sometimes the new system has better ways to accomplish the same goals, but identifying them is crucial for planning. Each gap requires a decision. Can we customize the new system to add this? Should we change our workflow? Is there a workaround? Can we live without it? Without gap analysis, Go Live Day becomes a disaster of discovered missing features and panicked workarounds. 45. Directed Exchange in Health Information Systems supports coordinated care by enabling secure information transfer between healthcare providers. A. Emergency data access. B. Secure information sending. C. Database synchronization process. D. Real-time data streaming. Can you guess the answer? Correct answer B. Secure information sending. Explanation. Option B is correct because directed exchange allows the ability to send and receive secure information electronically between care providers for coordination. Option A is incorrect because emergency access uses query-based exchange rather than directed information sending. Option C is incorrect because directed exchange sends specific information rather than synchronizing entire databases. Option D is incorrect because directed exchange involves discrete transfers rather than continuous data streaming. Directed exchange in health information systems operates like a secure medical courier service, enabling precise, intentional sharing of patient information between providers. This isn't about emergency data access when you don't know what you need. That's query-based exchange. It's not about synchronizing entire databases or streaming real-time data continuously. Directed exchange is specifically secure information, sending between known recipients for coordinated care. Picture this scenario. Your patient needs surgery at another hospital. With directed exchange, you select exactly which records to send. Recent labs, imaging results, medication list, allergies. Package them securely and send directly to the receiving surgeon. It's like sending a registered letter rather than posting on a bulletin board. The sender knows exactly what information is being shared, with whom and why. The receiver gets exactly what they need for care coordination. Nothing more, nothing less. This targeted approach maintains privacy while ensuring continuity of care. Directed exchange supports care transitions, referrals, and consultations where specific information needs to move from point A to point B securely. 46. Which medical facilities pioneered barcode medication? Administration implementation, establishing the technology standard for medication safety nationwide. A. Mayo Clinic Network. B. Veterans Hospital System. C. Cleveland Clinic Facilities. D. Kaiser Permanente Organization. Do you know the answer? Correct answer, B. Veterans Hospital System. Explanation. Option B is correct because the Veterans Administration Hospital in Topeka, Kansas first implemented BCMA, leading to nationwide adoption for safety. Option A is incorrect because the Mayo Clinic adopted BCMA after the Veterans Administration pioneered the technology. Option C is incorrect because the Cleveland Clinic was not the first facility to implement barcode medication administration. Option D is incorrect because Kaiser Permanente adopted BCMA following the VA's successful pioneering implementation. The story of barcode medication administration begins with a pioneering institution that proved technology could dramatically reduce medication errors. It wasn't Mayo Clinic, though they're innovation leaders. It wasn't Cleveland Clinic or Kaiser Permanente, despite their technical prowess. The Veterans Hospital System, specifically the VA hospital in Topeka, Kansas, first implemented BCMA and changed medication safety forever. This is significant because the VA, often criticized for bureaucracy, became the innovation leader that private hospitals followed. In the 1990s, the Topeka VA faced the same medication error crisis plaguing all hospitals. But instead of accepting errors as inevitable, they engineered a solution. They put barcodes on medications, scanners at bedsides, and created the verification system we know today. The results were stunning. Medication errors plummeted, wrong patient, wrong drug, wrong dose errors virtually disappeared. The success was so dramatic that BCMA spread throughout the entire VA system, then to private hospitals, and eventually the FDA mandated it. 47. Consumer-mediated exchange empowers patients to control how their health information is shared among their various healthcare providers. A. Provider authorization required. B. Patient manages sharing. C. Automatic data synchronization. D. Insurance company coordination. Can you guess the answer? Correct answer, B. Patient manages sharing. Explanation. Option B is correct because consumer-mediated exchange specifically gives patients the power to manage and control the sharing of their health information among different healthcare providers. Option A is incorrect because consumer-mediated exchange emphasizes patient control, not requiring authorization from the provider. Option C is incorrect because consumer-mediated exchange involves active patient management of sharing, not automatic data synchronization. Option D is incorrect because consumer-mediated exchange focuses on patient empowerment, not the coordination by insurance companies. Consumer-mediated exchange represents a revolutionary shift in health information control, putting patients in the driver's seat of their own medical data. This isn't about providers needing authorization to share, that's the old model. It's not automatic synchronization happening without patient involvement. It's definitely not insurance companies coordinating care. Consumer-mediated exchange means the patient manages sharing of their health information among providers. Think of patients as air traffic controllers for their medical data. They decide which doctor sees what information, when it's shared and for what purpose. A patient seeing a specialist can grant access to specific records from their primary care doctor. They can share mental health records with their cardiologist if medications might interact. They can prevent certain sensitive information from being shared while allowing other data to flow. This isn't just about privacy, it's about patient empowerment. Patients often know connections between their conditions that providers might miss. They understand their full health story across all providers. Consumer-mediated exchange recognizes that patients are the only constant in their fragmented care. 48. Workflow analysis helps identify areas where information technology can improve efficiency within interdisciplinary healthcare teams. A. Cost reduction opportunities. B. Technology improvement areas. C. Staffing requirement changes. D. Quality metric developments. Do you know the answer? Correct answer, B. Technology improvement areas. Explanation. Option B is correct because workflow analysis directly highlights areas where information technology can improve efficiency and support interdisciplinary teams by identifying bottlenecks and areas for technological intervention. Option A is incorrect because while technology improvements can lead to cost reductions, the primary focus of workflow analysis is on identifying specific technology applications, not directly on cost. Option C is incorrect because although technology can influence staffing, workflow analysis is centered on the processes themselves and how technology can optimize them, not on determining staffing needs. Option D is incorrect because workflow analysis provides insights that might inform quality metrics, but its direct purpose is to find opportunities for technology to enhance the workflow, not to develop the metrics themselves. Workflow analysis serves as the diagnostic tool for finding exactly where information technology can transform inefficient processes into streamlined operations. This isn't primarily about finding cost reduction opportunities, though savings may result. It's not about changing staffing requirements or developing quality metrics. Workflow analysis specifically highlights technology improvement areas where IT can enhance interdisciplinary team efficiency. Picture observing a nurse's medication administration process. Walk to supply room, unlock cabinet, count narcotics, sign paper log, walk to patient room, administer medication, walk back to nurse's station, document in 3 different places. Workflow analysis maps every step, every movement, every redundancy. Then it identifies where technology can help. Automated dispensing with fingerprint access eliminates counting and paper logs. Bedside documentation on mobile devices eliminates the walk back. Integration between systems eliminates triple documentation. The analysis doesn't just say, this is inefficient. It pinpoints exactly where and how technology can improve specific workflow steps. 49. Interface programs tell different healthcare information systems how to exchange data while maintaining consistent meaning and format. A. Security protocol establishment. B. Data exchange instructions. C. User access management. D. Network connection setup. Can you guess the answer? Correct answer, B. Data exchange instructions. Explanation. Option B is correct because interfaces are computer programs that specifically tell two different systems how to exchange data properly. Option A is incorrect because interfaces handle data exchange methods rather than establishing security protocols. Option C is incorrect because interfaces manage data exchange rather than user access permissions. Option D is incorrect because interfaces define data exchange rules rather than network connectivity setup. Interface programs are the universal translators of healthcare IT, enabling different systems to have meaningful conversations despite speaking different languages. These aren't about security protocols. That's handled by other systems. They're not managing who can access what. That's user permissions. They're not setting up network connections between computers. Interfaces specifically provide data exchange instructions that tell systems exactly how to share information. Imagine Hospital A uses System X that stores blood pressure as systolic/diastolic, like 120/80ths. Hospital B uses System Y that expects SBP 120, DBP 80. Without an interface, these systems can't communicate. They're speaking different dialects of the same language. The interface program acts as an interpreter with precise instructions. Take the first number before the slash, label it SBP. Take the second number, label it DBP. Add a comma between them. It translates dates from MM/DD/Y to YYMDD. It converts gender from MF to male, female, or to numerical codes. These aren't approximations. They're exact transformation rules that ensure no meaning is lost. 50. Physical safeguards for electronic protected health information include tangible security measures protecting hardware and facilities from unauthorized access. A. Password complexity requirements. B. USB port locks. C. Encryption protocol standards. D. Authentication timeout settings. Do you know the answer? Correct answer, B. USB port locks. Explanation. Option B is correct because physical safeguards include tangible protections, like locks on USB ports, preventing unauthorized device connections to computers. Option A is incorrect because password requirements are technical, dealing with the strength and management of access credentials, not physical security. Option C is incorrect because encryption represents a technical safeguard, encoding data to prevent unauthorized access, rather than a physical security measure. Option D is incorrect because authentication timeouts are technical controls determining session inactivity duration before requiring reauthentication, not physical security safeguards. Physical safeguards for electronic protected health information focus on tangible, touchable security measures you can see and physically interact with. Password complexity is important but exists in the digital realm. You can't touch a password. Encryption protocols are mathematical algorithms, not physical objects. Authentication timeouts are software settings, not hardware security. USB port locks are the perfect example of physical safeguards. Actual locks you can touch that prevent unauthorized devices from connecting to computers. Think about the security layers protecting EPHI, like a medieval castle. Encryption and passwords are like invisible magic spells. But physical safeguards are the actual walls, moats, and locked doors. USB port locks physically block the ports where someone might insert a flash drive to steal data. Locked server room doors prevent unauthorized physical access to systems. Cable locks secure laptops to desks. Security cameras monitor who approaches workstations. These tangible barriers work because many breaches aren't sophisticated hacks. They're someone walking up to an unlocked computer or plugging in a USB drive. You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.